Welcome to another illuminating episode of Optimal Anesthesia, in which we will investigate the anesthetic implications of carcinoid syndrome, a rare but interesting medical illness, and the role that different bioactive drugs play in its treatment. Carcinoid syndrome is a unique paraneoplastic syndrome associated with neuroendocrine tumors. The incidence is estimated to be 2 to 4 per 100,000 people per year. Carcinoid tumors are associated with multiple endocrine neoplasia, MEN, type 1 syndrome. The primary origin is often the gastrointestinal, GI, bioactive agents. At the heart of carcinoid syndrome lies the release of multiple bioactive agents, not just serotonin. While serotonin is indeed a central player, this syndrome doesn't spare any part of the body. Carcinoid tumors can be found not only in the GI tract but also in the lungs and other rare sites. Over 75% of these tumors originate in the GI tract, making it the most common location. As we dive deeper, it's important to understand that carcinoid syndrome isn't a one-agent show. While serotonin is a key player, it's not alone. Other bioactive agents such as histamine, kallikrein, prostaglandins, and tachykinins also contribute to the complex symptomatology of this syndrome. First, let's explore what carcinoid syndrome is and how it affects patients. Carcinoid syndrome is a paraneoplastic syndrome linked to neuroendocrine tumors, primarily originating from the gastrointestinal tract, though they can also be found in the lungs. These tumors release a cocktail of bioactive substances, most notably serotonin, histamine, kallikrein, prostaglandins, and tachykinins. Serotonin takes the lead in orchestrating this symphony of symptoms. When it's released in abundance, it sets off a series of clinical manifestations that include facial flushing, hypotension, tachycardia, diarrhea, bronchoconstriction, venous telangiectasia, and dyspnea. In severe cases, it can even lead to fibrotic deposits, a condition known as carcinoid heart disease. But how does each of these bioactive agents contribute to these symptoms? Let's break it down. Serotonin, it's the chief culprit. An overflow of serotonin results in flushing, hypotension, and tachycardia. It also stimulates the intestines, causing diarrhea. Histamine, it mainly contributes to flushing and bronchoconstriction. Kallikrein and prostaglandins, these substances can cause hypotension. Tachykinins, they are associated with diarrhea and bronchoconstriction. As you can see, the excessive release of these substances leads to a cascade of symptoms that can greatly affect a patient's quality of life. But it doesn't stop there. In a significant number of cases, patients with carcinoid syndrome progress to carcinoid heart disease. This cardiac complication typically presents as right-sided valvular lesions, often involving the tricuspid valve. These plaques can lead to tricuspid regurgitation, stenosis, and even pulmonary insufficiency. As if that's not enough, fibrous tissue growth from the excess serotonin can disrupt electrical pathways, causing arrhythmias. But the cardiac involvement doesn't stop on the right side. In some instances, left-sided heart lesions can occur, primarily in cases with intracardiac shunting, extensive liver metastases, or bronchial carcinoid tumors. Now, what's especially intriguing is the potential for a life-threatening scenario known as carcinoid crisis. This can be triggered by physical manipulation of the tumor, chemical stimulation, tumor necrosis due to chemotherapy, or even during the induction of anesthesia. It's characterized by severe flushing, blood pressure swings, cardiac arrhythmias, bronchoconstriction, and even mental status changes. So, it's evident that carcinoid syndrome and carcinoid heart disease are complex conditions with a multitude of clinical manifestations. Understanding the role of each bioactive substance in causing these symptoms is crucial for effective management. When it comes to carcinoid syndrome diagnosis, we have powerful tools. The standout is the 24-hour urinary 5-hydroxyindole acetic acid (HIAA) assay, measuring serotonin levels, a key player in this syndrome. Diverse imaging techniques like endoscopy, CT scans, and MRI act like detectives, hunting for tumors and metastases. Chromogranin A, CGA, is your trusty compass, pointing to carcinoid tumors, even the non-functional ones. The pentagastrin challenge test, akin to Sherlock Holmes, confirms the diagnosis alongside 5 HIAA levels. Treating carcinoid syndrome, superheroes and surgical symphony. The treatment journey starts with somatostatin analogs, octreotide and lanreotide, like superheroes, taming hormone secretion and alleviating symptoms. A novel treatment, teletristat ethyl, reduces serotonin and slows carcinoid heart disease. Picture a surgical symphony. Tumor debulking surgery downsizes, hepatic artery embolization is a strategic move, biotherapy led by interferon orchestrates tumor shrinkage, and chemotherapy whirlwinds to target tumor cells. These treatments are our knights in shining armor, battling this intricate condition. In the realm of carcinoid syndrome, one might say anesthesia is akin to a tightrope walk. Rapid changes in blood pressure are common among these patients, making invasive monitoring an advisable route. Imagine it as a watchful guardian keeping a close eye. Before the curtains rise for surgery, it's the arterial catheter that plays a significant role. It's akin to a safeguard, ready to manage potential hypotension, ensuring a smooth journey through anesthesia induction. Patients with carcinoid syndrome sometimes come bearing coexisting cardiac issues, introducing another layer to this intricate symphony. Here, we have options: monitoring left ventricular function with a pulmonary artery catheter or transesophageal echocardiography. Now, picture the anesthesia induction phase as the overture to a grand performance. It's crucial to avoid any stress responses. In this regard, our star conductor is propofol, the preferred choice. It's a maestro in suppressing the sympathetic response, ensuring a seamless start to the procedure. However, the use of succinylcholine comes with a twist. Debates are afoot. Why? Increased intra-abdominal pressure might lead to mediator release, stirring the waters. Pain management during anesthesia involves opioids without histamine release, much like a sweet serenade in this intricate opera. As the surgery unfolds, the maintenance phase becomes the heartbeat of the performance. It involves an ensemble, positive pressure ventilation, like the steady drumbeat of a heart. An inhalation agent, weaving through the melody. A non-depolarizing neuromuscular blocking agent, playing a supportive role. Opioid, often the virtuoso, fentanyl. And as a safe choice, nitrous oxide, harmonizing it all. For patients with chronic right ventricular valvular lesions and heart failure, anesthesia becomes a complex composition. To maintain harmony, we must avoid factors that might increase right ventricular work, preventing acute failure. As the performance concludes, it's the postoperative care that adds the final touch. There might be a need for an octreotide infusion, lasting up to 48 hours. Imagine it as the lingering encore, ensuring stability. But that's not all. To fine-tune the anesthetic score, we introduce antihistamines, aimed at reducing flushing and bronchospasm, a subtle reminder of the finishing touches. And let's not forget corticosteroids, used to reduce bradykinin production. It's like the afterglow, ensuring a smooth recovery. One final element of our anesthesia performance: tight glucose monitoring. Octreotide, known for its hormonal antagonism, requires a watchful eye to keep the balance. Thank you for joining us on this episode of Optimal Anesthesia. We hope you found this exploration of carcinoid syndrome informative. If you enjoyed today's episode, Please subscribe for more intriguing anesthesia topics. As always, stay curious, stay informed.